We now move to the next session on ROS of rearrangements in non-small cell lung cancer. And for the first talk, I would like to invite Dr. Sunil Pasricha, who is a senior consultant oncopathologist at Rajiv Gandhi Cancer Institute and Research Centre, New Delhi. And sir will be speaking on the interpretation of ROS rearrangements, FISH, IHC, and NGS. Just an announcement, the statistics workshop will start at 6 p.m. On the first floor. So those who are interested can join.
So, can I start? Yeah, good evening, everyone. First of all, I would like to thank the organizer for giving me this opportunity, and it's really a pleasure to be here with all of you. So, I'll be talking about the interpretation of ROS1 rearrangement in NSCLC. So, as we all know that 90% of the lung cancer are NSCLC, and the role of pathologists in the current era is not only just to diagnose a lung cancer, but also to find out the predictive biomarkers so that the patient can be put on the targeted therapies. And this is the survival of the patient with the drivers in lung cancer mutation consortium. And we can see that there is a good prognostic separation of the curves when the patients are put on the targeted therapy as shown in the orange curve as compared to when no targeted therapy was given or when no driver was identified. So the consortium demonstrate that the best outcomes are seen in the patient with identified drivers placed on targeted therapy with a median survival of 3.5 years. So although EGFR and ALK make the bulk of the targeted mutations, but there is a potential application in uncommon mutation, and ROS1 gene rearrangement is important. So the proto-oncogene role of ROS1 was first identified in brain tumors 2 decades back. However, the role in lung cancer was first reported in 2007 by Rykova et al., who identified 2 other protein fusion transcripts, CD74 and SLC34A2. And improved sequencing techniques have enabled the discovery of increasing number of fusion partners. So this is actually a bird's eye view of the main ROS1 fusion partners in ROS1 positive NSCLC, and we can see that approximately 85% are comprising of this partners, predominantly CD74, followed by EZR, SDC4, SLC34A2, TPM3, FIG or GOPC. So the fusion proteins are the robust oncogenic drivers that leads to tumorigenesis by the activation of these pathways, JAK-STAT, RAS, RAF, MEK, ERK, PI3K, AKT, mTOR pathway. So ROS1 rearrangements are frequently associated with young patients, women, never smokers. Predominantly, they show a lipidic, solid or acinar pattern. They are frequently TTF1 positive, frequently diagnosed at advanced stage and higher frequency of brain metastasis. Regarding the incidence and implications, the rearrangement occurs in 1 to 2.6% of NSCLC. The effectiveness of the therapies with TKI in NSCLC depend upon the accurate determination of the genomic status of the tumor. Detecting the ROS1 rearrangement offers the patient the opportunity to receive the highly effective targeted therapies. So this was our institutional study published showing the incidence of 2.8%, which was a relatively higher frequency in the North Indian patients. So these are the testing modalities. The IHC, which is primarily done for the screening, but a very important tool and the orthogonal testing confirmation by FISH and NGS. So IHC, the most popular clone is the D4D6 from cell signaling, and that has been utilized in the clinical studies and has stood the test of time. And I'm personally using it for the last 5 years in my department. The other popular clone that has emerged just last year, that is SP384 by Roche. So the guidelines recommend the use of IHC as a screening method, and clones have a very high sensitivity of 90 to 100% as compared to FISH and NGS. And that's how it should have a very high sensitivity, because if the patient is missed at this point, the patient is unlikely to be tested again. So the ROS1 specificity is variable, ranging from 70 to 90%, and it depends on the clone used and the positivity threshold applied. But the bottom line is that all positive IHC cases must be confirmed with orthogonal test before starting on targeted therapy. So these are some cases from my case library, and various patterns have shown the ROS1 positivity. So this was showing a acinar pattern of growth, and we can see a strong and diffuse cytoplasmic expression of ROS1. And this turned out to be positive for the FISH rearrangement for ROS1. The second case showing a solid pattern with a very highly pleomorphic, mitotically active and tumor giant cells were also seen. However, in this case, the expression of ROS1 was heterogeneous again, but eventually it was positive for the FISH rearrangement testing. Even with the micropapillary pattern also, we found a strong and diffuse expression, eventually positive for the FISH rearrangement. So immunohistochemistry has advantages. It's a very effective screening tool and requires just one section. Cell blocks can also be used. It avoids unnecessary fish testing, which is expensive and tedious. And the very important thing is that it has a very short turnaround time. So the medical oncologists do get across the clinical situations that actually require expedition of results. So many a time, like my colleague, Dr. Ullas, he tells me even in the evening that I'm anticipating a ROS1 or a ALK mutation in a particular patient. So by next day, by 12 or 11 a.m., I'm ready with the results of the immunohistochemistry. So it's not even a single day. So standardization and validation is very easier. More labs can do it. It's not an arduous task. So disadvantage, different interpretation criteria were suggested with the different cutoff points. For example, positivity defined with moderate or a strong intensity, and few authors have suggested a H score of more than 100 or a more than 150 as a cutoff. But currently there is no standard cutoff criteria accepted, and it is recommended that each laboratory validates its own interpretative range. And there are three practical challenging scenarios in ROS1 immunohistochemistry that has important clinical consequences. So I'll be just taking off one by one. So first is when you have a true positive immunohistochemistry result, but eventually not confirmed by the orthogonal method. So that can be attributed to the limitations of FISH and NGS because they can be false negative. Or you can have an unexpected discordant equivocal or a low confidence in a confirmatory test. Even the most expensive and sophisticated NGS panel might fail to detect the fusion. And the risk of false negative increases when a DNA-based NGS approach is used. So the precise knowledge of the coverage of the assay and its real-world performance can help to rule out a NGS false negative result. And it is now recommended that IHC positivity and questionable ROS1 orthogonal test result be confirmed with another technique. The second challenging scenario is you have a false negative IHC results. So patients with a negative IHC results are unlikely to be tested again for this biomarker. So one should actually consider the overall context. So if clinically the patient is never smoker, young age, histologically you have a acinar or a solid pattern with signet ring or mucinous cells, and also the genomic context. If the patient is negative for the other driver mutation, so one should go for a multi-gene assay, NGS testing. The third scenario is the significant ROS1 expression can be present in ROS1 amplified tumor or ROS1 negative tumors containing other oncogenic drivers, mainly EGFR mutation, also KRAS, BRAF, ALK, and HER2 abnormalities. So if confirmatory method by break apart FISH negative for ROS1 gene rearrangement, one should go for a NGS testing. So this is the workflow algorithm of the ROS1 IHC interpretation along with the challenging scenario that I've just explained. So coming to the break apart FISH, it's a gold standard to diagnose the ROS1 gene rearrangement, and it has played a vital role in the initial clinical trials of crizotinib. It is done by using a dual probe break apart design with two different fluorochromes labeled on either side of the fusion breakpoint. So this is the probe we apply. One is at the centromeric end, this green probe. So this green probe at the centromeric end, and this is the breakpoint, and the orange probe is at the telomeric end, the 5'. So this is the criteria and the prerequisite for a positive test that more than 15% of the cells should show separation of both 3' and 5' probes, or more than 15% of cells show isolated 3' centromeric signal, but not 5' signal. And the prerequisite is that more than 50 viable tumor cells must be present to validate a positive finding. And these 50 cells that we evaluate should be in a sequential. There should be no cherry picking that this particular cell is showing a break apart signal and that particular. So in uncertain cases, if there is a range of 10 to 15%, a correlation of another diagnostic test is recommended, IHC or NGS. So this is showing the ROS1 rearrangement when it is absent. So there will be no break apart, and there will be a fused yellow signal will be seen as shown by the white arrow. And when there is a ROS1 gene rearrangement is there, so the classical pattern is showing one fusion signal and two separated 3', 5' signals. And these two signals should be separated by twice the diameter of the signal. This is the atypical pattern with the native ROS1 fusion signal and isolated 3' signal. That is the green, which is towards the centromeric end without the corresponding 5 signal. So the false negative break apart FISH can occur when certain fusion partners, primarily GOPC ROS1 or EZR ROS1, they are known to cause a false negative break apart FISH. It is the inability of certain FISH probes to detect rearrangement that result from small genomic deletions, and there can be complex staining pattern also in which many atypical fusion doublets are seen, but the percentage of cells with the split signals was below the 15%. So this was the study published in JTO. So showing the comparison of the molecular testing modalities for the detection of the ROS1 gene rearrangement. So the fish was negative in 2 out of 20 cases. So in the first case, it was attributed to the GOPC fusion partner. So the deleted region was so small that leaving behind the complementary region for the binding of both the probes. So it was false negative. The second case.
Sir, sorry to interrupt, but kindly conclude your talk.
Yeah.
We are running out of time.
Okay. So pulse break apart can be because of the unproductive rearrangements and aberrant probe hybridization. So NGS has a advantage that it has the potential to detect several fusion, not only the known, but also the novel fusion, and also other targeted multiplex panels able to analyze the hotspot region of all the approved molecular biomarkers. So even the partners with a very low frequency can also be identified with this. So DNA and RNA based sequencing, I think the advantages and disadvantages have already been discussed in the previous. So I can conclude that the ROS1 positive NSCLC have been identified as a distinct molecular class. The effectiveness of the targeted therapies depend on accurate determination of the genomic status of the tumor. It's incumbent upon the pathologist to make the testing reliable by optimizing the pre-analytical, analytical, and the post-analytical steps. And multidisciplinary communication is essential for the quality information within the required time frame, and that too at a judicious cost. Thank you so much.